people, this is Dr Muskaan this side, and today I'm going to discuss one very beautiful case. It is all about community-acquired pneumonia. Let's dive deep into this case and enjoy this interesting case. Here is 44-year-old male who has came to ER with chief complaints of shortness of breath, fever, cough with sputum since morning. So first of all, I'm going to tell you differentials of all chief complaints. When shortness of breath come in mind, it can be due to your lung, it can be due to your heart. So for lung, you have to remember P3A3C. P3 means pleural effusion, tension, pneumothorax and pneumonia. A3 means anaphylaxis, asthma and allergy, and C is COPD. And for heart, you have to remember FMT. F is failure, heart failure, M is MI, and T is tamponade, cardiac tamponade. Second complaint was fever. For fever, you have to remember, just a second, yeah. For fever, you have to remember differentials. Toxic look, so you have to remember for toxic, if it is looking toxic, patient look, it is TB, typhoid and septicemia. If it is marked perspiration, means patient is sweating badly. Your differentials will be rheumatic fever, pubic liver abscess, brucellosis and septicemia. If there will be severe myalgia, means fever is associated with your muscle pain, your differentials will be dengue, influenza, chikungunya, leptospirosis. If there will be purpura, the differentials will be acute leukemia and septicemia. If there will be convulsions, it will be cerebral abscess, tuberculosis and meningitis. If there will be lymphadenopathy, the differentials will be TB, lymphoma, secondary syphilis, SLE and AIDS. Your third chief complaint was cough with sputum. So what are the differentials for acute cough? It is allergic rhinitis, allergic bronchitis, asthma, COPD, common cold, congestive heart failure, pneumonia, malignancy, sinusitis, GERD. Now cough was also associated with sputum, so we have to see the color of the sputum and we have to make the differential. So if it is red color, it is your pneumococcal pneumonia. If it is your green color sputum, it will be cystic fibrosis, lung abscess, it will be pneumonia, it will be bronchitis. If it will be pink color, it will be your acute pulmonary edema and alveolar cell carcinoma. If it will be white color, it will be COPD, asthma and chronic bronchitis. Other chief complaint was your chest pain. For chest pain, if patient is coming in emergency, your differentials will be there is one mnemonic to remember, that is PETMAC, PETMAC. P for pulmonary embolism, E is for esophageal rupture, T is for tension pneumothorax, M is MI, A is aortic dissection and C is cardiac tamponade. Okay, so this is all I have summarized, what all chief complaints patient has come with and what all differentials should come in the mind of the doctor. On arrival, ABCS was done, airway was patent, there were no signs of airway obstruction. So I have checked the airway, signs of airway obstruction. What were the signs of airway obstruction? Which I have ruled out, that is choking, dysphagia, dysphonia, hoarseness of voice, patient is lying on bed and he is not able to breathe, patient is holding his leg and I am not feeling like breathing. These all are signs of airway obstruction which were absent in that patient. That means patient was, airway was patent. अगर नहीं होती पेटेंट तो क्या करते हैं, इंट्यूबेशन. On breathing assessment, respiratory rate was 20 per minute. There was labored breathing, SpO2 was 95% on room air. So what all signs and symptoms are for respiratory distress? That is cyanosis. Patient is feeling dizziness. Patient is feeling there is abnormal breathing. There is slow and rapid breathing. Patient is gasping. Either he is blue, either he is very pale, means whitish in color. Patient is fearful and apprehensive. Okay. So these all are the signs of the respiratory distress. On circulation assessment, pulse rate and BP were taken. Pulse rate was 78 per minute, BP was 124/64. Circulation assessment is normal. On sensorium, GCS was E4, V5, M6. That is, GCS was 15/15 means he was opening spontaneously, verbal response was oriented and motor response, he was obeying the command. So there is one mnemonic to remember, Glasgow Coma scale. Okay, there is three components. One is your eye, second is your verbal and third is your motor. For eye, you can remember ESPN. ESPN is 4-3-2-1. E, eye is opening spontaneously, S to the sound, P to the pain and N means not opening. Next is your verbal response. In that your mnemonic is R, country, win. R 1 2 ठीक है, 5 4 3 2 1 oriented, ठीक है, country, confused, win. 3 2 1, that is your words, incomprehensive sounds and no response. Next is your motor response. In that mnemonic is can't live without fan. ठीक है, फैन का FAN आएगा, बाकी can't live without ऐसे आएगा. 654-321. OB command on 6. Localized to pain on 5, that is live. ठीक है, without 4. Withdraws to pain 321. FAN, FAN, flexion, abnormal extension and no response. Okay. Now after ABCS, what we have, that is the positive history in the patient. There were 4 positive history in the patient. That was fever, which was listed with chills. Second was 2 to 3 episodes of hemoptysis. Third was history of smoking was there, he was chronic smoker. And fourth was there was epistaxis present, 2 to 3 episodes. So I will just tell you differentials which will come in the mind of the doctor when they will hear these chief complaints and what all they have to think. So differentials of fever with chills is acute lobar pneumonia, acute pyelonephritis, agranulocytosis, abscess, it can be lung abscess, blood transfusion, cholangitis, filariasis, malaria, SBE, that is your spontaneous bacterial endocarditis, septicemia, thrombophlebitis, pyrogen reaction after fluid infusion, and UTI. Your second chief complaint was hemoptysis, that is blood stained sputum. Already we have green colored sputum of this patient. I told you earlier that I will discuss it later on because that was on day 2. On day 1 it was blood stained sputum. So what are the differentials of hemoptysis? The mnemonic is battle camp. BATTLECA3MP. Oh my god, itne sare mnemonics, itne sare differentials. Yes, you have to remember it, you have to mug it up. That's जितना ज़्यादा निमोनिक्स और ये डिफरेंशियल्स याद होंगे उतना ज़्यादा केस इजी होगा, इतना ज़्यादा मज़ा आएगा आपको देखने में, पढ़ने में. ओके, सो डिफरेंशियल्स ऑफ हेमोप्टिसिस इज बैटल. ठीक है, ब्रोंकाइटिस, ठीक है, ब्रोंकिटिस, ट्यूमर, टीबी, लंग एब्सेस, एम्बोलाई, दैट इज योर पल्मनरी ऑफ कोर्स, कैम्प, CA3MP, कोगुलोपैथी, ऑटोइम्यून डिसऑर्डर, AV malformation, alveolar hemorrhage, mitral stenosis and pneumonia. Okay, now history of smoking since 15 years. So what are the differentials you will come in mind when there will be patient who is chronic smoker? Brain में there will be addiction and stroke. Eyes में there will be wrinkles. Mouth में there will be tooth decay, gum disease, है ना. Finger stained होंगी. ठीक है. Throat कैंसर हो जाएगा, लंग का कैंसर हो सकता है, हार्ट डिजीज या हार्ट अटैक का प्रॉब्लम हो सकता है, लिवर कैंसर, स्टमक कैंसर, किडनी कैंसर. ठीक है, रीनल ब्लड वेसल्स कैसे हो जाएंगी, सिंपल ब्लड वेसल्स कैसे हो जाएंगी, कंस्ट्रिक्ट हो जाएंगी. यूट्रस कैंसर, ब्लैडर कैंसर, ऑस्टियोपोरोसिस एंड इनफर्टिलिटी एंड इम्पोटेंस इन मेन. सो दीज ऑल आर द डिजीजेस व्हिच आर एसोसिएटेड विद स्मोकिंग. Now another chief complaint was epistaxis. What are the differentials of epistaxis? Local, in general and idiopathic. Idiopathic, of course, it is not clear. Local med is infection, trauma, foreign body, neoplasm of nose, atmospheric change and DNS. And general med is hypertension, pregnancies, liver cirrhosis, chronic nephritis, and idiopathic med is not clear. So further, after taking this differentials and the positive history, I am asking about, now there is negative history of the patient. There was no TB or TB contact, there was no seasonal or diurnal variation, there was no dust allergy, there was no alcohol or tobacco addictions, there was no hypertension, type 2 diabetes mellitus or thyroid disease, there was no MDI, DPI use. Okay, on examination when pallor, icterus, clubbing cyanosis and edema was examined, there was presence of mild pallor. Investigation picture of the patient: CBC shows anemia and thrombocytopenia, KFT shows increased urea level, and there was AKI present. How we check AKI? According to the KDIGO classification, in which we see the urine output and creatinine levels. There is 1, 2, 3 grade. First grade says 1.5 into baseline and urine output less than 0.5 ml per kg per hour for 6 to 12 hours. Next is your grade 2, stage 2, in which there is serum creatinine should be 2.9 into baseline and urine output should be less than 0.5 ml per kg per hour for more than 12 hours. And stage 3 is 3 into baseline and urine output should be less than 0.3 ml per kg per hour for more than 24 hours. LFT picture shows hyperbilirubinemia, serum transaminitis and increase in alkaline phosphatase. How we see serum transaminitis, my dear friends? When there is increased level of SGOT and SGPT, we say that there is serum transaminitis. NT-proBNP levels was raised. What is NT-proBNP? NT-proBNP is N-terminal prohormone brain natriuretic peptide it tells us about some cardiovascular problem. Basically, this is a protein which is present in heart, and when its level increases, that means there is some stretch, there is some stress which is produced in the left ventricle, and which leads to its hypertrophy, which is telling your kidney to release your natriuretic, means sodium and water. The word brain which comes in this NT-proBNP is because the first time this was detected in brain, but particularly it is the protein, it is the hormone of the heart. Okay, so SARS-CoV-2 real-time PCR was negative of this patient. Malaria peripheral smear was negative. Urine culture and sensitivity was negative. AFP stain for sputum, there was no acid-fast bacilli. That means I have ruled out what? Tuberculosis, because investigation of choice to see if TB is present or not, it is your AFP. D-dimer was normal, it was 0.22 microgram per ml. Ultrasound shows mild to moderate right side pleural effusion, moderate splenomegaly, and features of sequelae of CLD observed. PT-INR was 15.6 and 1.12. Troponin I plus was less than 0.01 nanogram per ml. ECG, I have seen there was presence of LVH. How I have seen through Sokolow-Lyon criteria. Sokolow-Lyon criteria says S plus R wave should be 35 mm, and there will be in V1, V2 there will be deep S wave, in V5, V6 there will be long R waves. Okay. Dengue test was negative. On chest X-ray, I can observe right-sided pleural effusion. There was blunting of CP angle. There was increased bronchopulmonary markings on the right side. There was presence of Sheliot sign. What is Sheliot sign? Sheliot sign says that there is loss of definition of the upper border of the heart. In ABG, there was type 1 respiratory failure. There was alkemia, hypoxia, decreased PCO2, and normal bicarbonate. ECG shows ST elevation MI, because there was ST elevation in V2 to V6, one lead and AVL lead, in reciprocal ST depression in third and AVF lead. Okay. Further, there was mild shock index, and Q-SOFA score, when I calculated, it was score 1. Swine flu, H1N1, influenza A and B was not detected. Culture and sensitivity shows Pseudomonas aeruginosa. This was day 2, and patient was having green color sputum also. So Pseudomonas was there in culture. What all differential should come in your mind when Pseudomonas is in the culture? It should be endocarditis, meningitis, pneumonia, septicemia, endophthalmitis, malignant external otitis. Culture and sensitivity of the blood shows no growth. Now pulse pressure of this patient was 45 mmHg. ठीक है, अगर पल्स प्रेशर 100 से ज़्यादा होता है तब बोलते हैं कि सेप्टिक शॉक है. मैनेजमेंट गिवन टू दिस पेशेंट वॉज गोल्ड स्टैंडर्ड जो देते हैं. वन इज़ योर बीटा लैक्टम एंड अदर इज़ योर मैक्रोलाइड. बीटा लैक्टम is your piperacillin and tazobactam, and macrolide is your azithromycin. And other treatment which was given was nasal spray, that is your Brotoclot to control epistaxis. Syrup Repetus Plus was given to treat dry cough. Injection Pantof was given to treat GRD. Tablet Tamiflu was given to prevent influenza. Injection Hydrocot was given to prevent swelling. Nebulization was done with Budecort to clear the airway. Injection Trenexa was given to control the internal bleed. Syrup Loose was given to treat the constipation, and tablet Ducolex was given to clear the airway. Okay, so I will tell you a little about community acquired pneumonia, and before telling that, I just want to take you back. I just want to take you towards the differentials. Okay, shortness of breath complaint थी, उसके differential में pneumonia था. Fever की complaint थी, fever with chills में pneumonia है. Sputum green color pneumonia है. Cough pneumonia है. चेस्ट पेन निमोनिया है. वेट, चेस्ट पेन में निमोनिया नहीं था, ठीक है, चेस्ट पेन उसको वैसे भी माइल्ड था, ठीक है। फर्दर उसके बाद क्या डिफरेंशियल्स देखे थे हमने, फीवर विद चिल्स में एक्यूट लोबार निमोनिया था, डिफरेंशियल्स ऑफ हेमोप्टिसिस में भी निमोनिया था, स्मोकिंग रिलेटेड डिजीज़ में हार्ट अटैक एंड हार्ट डिजीज़ आया था जो उसके साथ रिलेट कर रहा था। वो भी क्योंकि उसका CKMB बढ़ा हुआ था, उसका NT-proBNP बढ़ा हुआ था, ECG में MI आ गया था। सो वो फ्यूचर रिलेटेड प्रॉब्लम है, अभी फ़िलहाल इतना नहीं है ना। एपिस्टेक्सिस में इट कैन बी इन्फेक्शन। सो ओवरऑल दिस केस वॉज एंड योर चेस्ट एक्सरे, ब्रोंकोवैस्कुलर मार्किंग्स दिख रही है, शीलेट साइन दिख रहा है, ये सब निमोनिया के फीचर्स हैं। उसके बाद सूडोमोनास एरिजिनोसा जब मिल गया तो निमोनिया है ना। Now I will tell you a little about community-acquired pneumonia before ending this video. What is community-acquired pneumonia? It is acute infection of your lung parenchyma in which there is type 1 respiratory failure, which is most commonly found, okay, in ABG. The organism which causes this pneumonia is Streptococcus pneumonia, Staphylococcus aureus, Pseudomonas aeruginosa, Haemophilus influenzae, and Legionella. The chief complaints will be fever, cough, and shortness of breath. Signs will be tachypnea, tachycardia, abdominal pain, and hiccup. You can use SCOP 65 criteria to diagnose pneumonia when the patient has came in emergency. C stands for confusion, U stands for urea levels, which should be more than 7, R stands for respiratory rate, which is more than 30 per minute, BP is less than 90/60, age is more than 65. So minimum score should be 3 to admit the patient in ICU. Investigation picture in sputum culture, we suspect the organism in AIP sputum to rule out tuberculosis. Chest X-ray will show increased bronchovascular markings, air bronchogram, Sullivan sign, that is loss of definition of right heart border. ABG will show type 1 respiratory failure. Management in severe ICU patients will be piperacillin and tazobactam, which is your beta-lactam, and tablet azithromycin, which is your macrolide. That's all. I really enjoyed making differentials on this case, and I hope you have also enjoyed listening to the case history. Dr. Muskaan signing off now.